questions about anything that we covered last week about the wound? Did the wound assignment? We're all good? Move forward? Okay. All right, so just like in everything else in hand therapy, we abbreviate, right? So the doctor will likely not write all that out on your prescription. They may just write FTSG, right? So be prepared for a lot of abbreviations. So, split thickness skin graft, whole thickness skin graft. So it's just the depth of the tissue that they're going to take. And they show in this picture here the depth between a split thickness skin graft and then a full thickness skin graft and how much of the tissue that they're going to take. And then there's a free tissue transfer where they take tissue from one spot over to another in isolation, right? And then these pedicled flaps are times when they need blood supply. So these are the situations where you have a large area that you need to cover, okay? A large skin area that may be deep that you're worried about it surviving. So what they'll do is say, and there's lots of ways that you can flap. There's little ways to flap and big ways to flap. So a little way to flap would just be like a cross finger flap. They'll take skin from one finger, flap it over onto the other finger, and sew it together, and then take skin from somewhere else that would be just a free tissue transfer to cover where they took the flap. Then the fingers are held together for a period of time until the graft's going to take, and then they divide the flap and open the fingers. You could get like a thinner flap where maybe the tip of the small finger was amputated and it's a big spot and it needs blood to heal. They'll take the tip of the small finger, sew it into the thinner eminence, make it flat, keep it there for a period of time, and then after so many weeks release it, and then the finger's free, and then they take a place from somewhere else to cover where they took the flap. A bigger one would be the groin is another area that you would flap. So say you have, I had a patient that was bitten by a brown recluse spider when I lived in Ohio, and she had a huge, deep wound on the dorsum of her hand. Huge wound. They took a pedicle flap from her groin, sewed it over because we sometimes have a lot of extra tissue there, right? And sewed it on there. Her arm is there for a few weeks, 2 to 3 weeks, depending on. Let the blood supply take, free the flap, her arm is free, and close the spot. Okay? So when you see flap, you know that blood supply was taken with it. And there is also going to be some other things that you have to be worried about. So if someone's hand was sewn in their groin for 3 weeks, what should I be really worried about? Infection? No.
Proximal strengthening.
Proximal strengthening, but what first? Huh? Contracture of?
Your flexors.
Shoulder. My shoulder's been stuck in a bent position, would not be able to frequently, periodically get up and move, right? I gotta get that shoulder moving. I gotta assess it. I gotta look for proximal weakness, but I gotta get that shoulder moving as important as I need to get this moving, okay? Same thing if my small finger was a flap. Oh, my ears are ringing. Anybody else? If the small finger was sewn into the thinner eminence, what would I be worried about? Small finger flexion contracture, right? So with a flap situation, you're going to be worried more likely about So this next picture is just showing again the depth of the different types of grafts, whether it's split thickness or full thickness. So, and this just shows some areas. So if you're doing a split thickness graft, it's going to be taken from, and this is not thick, it's thigh, I noticed this after I already posted it, and I didn't want to change it because I wanted to point it out. It's not thick because it's a split thickness. It's a thigh. I don't know why I did that. Thigh, buttock area, or abdomen, okay? This, sometimes there's meshing. You know what I mean with meshing?
Yeah.
You know how when you make a pie crust and you take that little roller thing and then it makes divisions and then you can take it and cover your pie? That's what they do with the skin. So if they mesh it, they can cover a larger surface area. Should there be a large burn? Sometimes when you'll see a burn, it may look spotted, kind of, and that's because a meshed graft was used because it was a large body area or body surface burn situation. So they mesh it to cover a larger area. So this just shows the benefits of each. But again, whenever we have skin taken from one place to another, we have to worry about not moving it initially. And the book gives us guidelines, right? But the doctor tells us when it's okay, because the doctor's gonna look at the graft. If that graft is not healing as quickly or they're worried about it, they're not gonna move it. So even though it's been 3 days, you still have to check with the doc, because they may say, oh, this graft is not taking very well, I don't wanna move it for 2 more days. If we move it too early, the graft won't take, needs a new graft, right? So it's really important to communicate. And then with the split thickness graft, the donor sites can just close by secondary intention, and you know what that means, right? Just heal from the inside out. A full thickness graft is going to be taken from these places for the upper extremity. The hypothenar eminence, which would be here, the medial aspect of the arm, here, the groin. These grafts will have improved cosmesis and less contraction, meaning they'll be able to move better. So if it was going to be over a joint space, might be better to be a full thickness graft versus a split thickness graft. Does that make sense? Because as we move, the skin in the dorsum of my hand really has to elongate to allow wrist flexion, right? So better for small, clean wounds, but it's going to take a long time for you to have good vascularity. Doesn't mean maybe you can't move it. Again, you're going to have conversations with the doctor. But then the donor site would just be closed with primary intention, which means it's sutured or stapled closed. Usually in the upper quadrant, suture. Yeah.
So if you are working with somebody who, for some reason, they couldn't get a graft from them, so they took it from elsewhere.
Right.
Is the healing or the vascularity time different?
I don't think it makes any difference from
Okay.
my understanding.
The
Because you
doctor
could
will
take
look for reduction.
a graft from you could take a donated graft, they can make graft, they can grow
Okay.
skin, so there's different ways that they can do it.
Okay.
But usually when you're dealing with people not burns, like not burn unit, because burn unit, you have sometimes big skin coverage where you might see things like a graft, skin that's grown, or graft that's donated, right? And working in the upper extremity world, it's more likely their own tissue that they would use, because it's not that big body surface area. Then free transfer, again, taking one spot to cover another, may require things like a vein graft, which they may take from the lower extremity, and then primary closure or a skin graft for the donor site. So they may take a graft depending on how much tissue or the size of it, or they might, if there's a lot of excess tissue, they can maybe close it after the free tissue transfer. It just depends on where it is and how much skin you have available. So with the pedicle flap, flap, that means I'm taking blood supply with. So it's going to be about 3 weeks before that gains vascularity. About. So it depends, right? The doctor's going to be watching the graft or the flap, looking at it, watching how things go.
Where would be the primary site that you see these kind of patients? Would it be like acute care or a burn unit or?
I see them in outpatient hand therapy all the time.
For even the pedicle?
Yeah, all the time. because it depends on, you know, what they have to reconstruct. Like, if the wound or the area is on something, you know, everything has a different structure and function. So if you took, say you needed to graft the end of a finger, the end of our finger, first of all, it takes a lot of abuse, right? We're always picking up things, we sweep, we rake leaves, everything that gets also, if you feel the tip of your finger, it's like cushy, right? It's meaty, right? If you just took a little thin split thickness graft sometimes, and depending on the damage, you know, and put it over a finger that lost that meaty in whatever the injury was, you're gonna have a hypersensitive finger that maybe the graft won't take, you know. So you might need something that's deeper and with blood supply to make it take and be more valuable. I've seen kind of doctors do that before, and the patient ends up having a finger they don't use because they don't have that meaty, you know what I'm saying? Is it clear? Like, you need the meaty on your fingertips to be functional. If it's bone right underneath there, you aren't gonna be using that finger to pick up anything. It's gonna be too sensitive. We need the pads. I mean, look at the bottoms of dogs' feet, right? What are those like, right? They're meaty and coarse, because they take walking on dirt, walking on pavement. Like, our feet on the bottom are meaty, right? Especially in the summer if you walk on the gravel, right? But our hands are not as meaty, but we still have cush for function.
That leads to a second question, actually, because I know, like, at the bottom of our feet, we have an extra layer. Like, with the skin, we have a, I'm trying to remember the name, that
I don't
there's,
know.
like, so
Like
would
a
you have
callus.
to take, like, if you're doing something on the bottom of the feet, you have to take something that has,
I don't know. Sometimes they take skin that, they try to match the skin, but like, some skin grows hair and some skin does not, right? You probably don't want hair growing off the end of your fingertips, right? That would be strange, right? You'd have to shave it all the time, nair. So they try to match skin to areas, whether it's hair producing or not. But I haven't really dealt with the bottom of the feet, so I don't know. But they try to take matched skin. But sometimes someone might have hair where they don't want hair, because that's what they had to use. But I've never had anyone with hair on the tips, because there's other options, you know, those with that little space. All right. Okay. So, and again, we do the same thing with a flap or a graft. We're gonna do these same things, right? We're gonna move them as soon as we get doctor's orders to move them. We're gonna watch for wounds. We're gonna watch for blood supply. We're gonna watch for infections. We're gonna manage the edema, because edema makes what? The more edema, the more scar, right? And then we're gonna work on the scar. So we're gonna do those same things with all of our patients. But the biggest thing to note with a flap or a graft of any kind is you have to find out, is it okay to move it or not? And if you don't know, you have to ask. And a lot of times we don't know things because, you know, we get a referral and it's really ambiguous, and sometimes, especially new graduates, I know that I was scared to death to call the doctor. I don't know if we've already had this conversation, but you really have to get past that, because you have to find out. Because if you don't ask and you don't move them when they're supposed to move them, you won't get another referral from that physician, because you've lost their confidence. Or if you work at that physician's office, it's way worse to get yelled at for not doing what you're supposed to do than to call and ask the question. So call and ask. You don't talk to the doctor, just talk to the nurse. Say, I want to leave a message for Dr. So-and-so, is it okay if I, and then you don't necessarily have to talk to the doctor regardless. Some doctors are more approachable and welcoming for questions than others. Okay. We're moving on to Dupuytren's. So who has heard of Dupuytren's contracture or seen it before? A few. Okay. Who has been on the Ireland trip already? Did you see any Dupuytren's contracture when you were in Ireland? I saw it every day when I was there last year. 'Cause so we'll look at because the most common in those with Northern European descent. So, so I saw it every day when I was in Ireland. So there's a genetic origin to this disease, okay? It's this Northern European descent, and it's typically onset at age 50 to 60, so this is not a young person's disorder. It's something that happens later, and men are affected more commonly than women, but I have seen women with it as well. So what happens with this is what it looks like, and once you see it, you'll remember it, and you'll never forget it, okay? So it's an overgrowth of fascia that occurs in the palm of the hands. It can present, I'm going to go backwards kind of. Initially, this is my friend Bob actually, and it can present initially just with a little bit of puckering that might feel firm. And the patient might even complain of a click or so when they move their fingers, so you may be thinking trigger finger, right? But this usually isn't painful with palpation. It just feels hard and dense, okay? So this is how it is when it first starts. And the patient may feel like thickness, and they may feel like they're starting to have some trouble with straightening their, might feel a bit tight if they're having trouble straightening their fingers, okay? Oops. And then it might start to progress with some puckering, okay? And these are different people, this is still not Bob, but, and then nodules also might present in the palm of the hand. And then as it advances, it can create these cords that develop, and then it can actually pull the finger down into a contracted position in flexion. And this guy has both of his ring fingers, but it can happen in any digit. It's not only on the ring finger. In fact, all the cases that I have here show more the ulnar side of the hand with involvement, but it can be in the thumb, it can be anywhere. So, like when I was in Ireland, you know, I would go to shake someone's hand and they would shake it like that. And I would know, or maybe it was, I can't make myself do it because of my, God, I'm having words, yesterday I couldn't think of a word, I'm like, it's the same, I can't think of it. Because of your EDC, your junctura, oh my God. So I can't do that, you know, but it's easier with the ring finger. But, so you would go to shake their hand and their finger would be contracted, so I would know which Dupuytren's in there, right? So that's what it looks like. Once you've seen it, you'll never forget it, okay? So there's a mild case. So it's really this overgrowth, this increased cellular process with the fascia of the hand. First seen as a nodule, then can pucker and lead to like these cords, and then eventually lead to contracture of the digits and flexion. So this is a slow-growing disorder. I don't know if it can be, if what the literature says out there, if it can be progressed with trauma, but I've had patients report that following a trauma, like maybe an injury to their hand or something, that they felt like it grew faster. But how would we know if it wouldn't have grown at that rate anyway? You know, it's a single case, you know, we don't know. But typically, in Bob's case, right, he may feel this in his hand, but he's not a surgical candidate, right? It's not obstructing his function in any way. And then when we look here, still, looks like they have maybe a little bit of lacking of extension of the MP, but maybe 10 degrees, right? Not anything significant, probably still really functional, right? But then when we get to here, this is limiting function, right? And then there's this gentle balance of when do we operate? Do we operate now or do we wait till here?
Does it usually occur in the hands bilaterally, or is it?
Because it has a genetic origin, you can get it, if you have the genetic origin to have that, you could have it in both hands. It may show up in one hand and not show up yet in the other, but it can also occur on the soles of the feet, because it's the same type of fascia. And in men, it can also occur on the underside of the penis, and that would be called Peyronie's disease.
And is it usually like, does it show up later in life, or is it usually?
50s to 60s.
I have too, that so I have 3 friends who got it in their 30s, and the earlier a bit appears, the more aggressive it is, so they develop like really, really fast. It's not normal, but they don't have long time.
It's really variable, so if you get someone who's 85 and looks like that, do you operate? Like, how long are they gonna live? Is it really it's a slow growing situation. Even if they live to 95 or 100, what's their life demand? What's the risk of doing surgery? Probably not a big deal, right? But if you develop this and you're 54, right, a huge impact in your function. Can you grab a cup easily with that hand with your finger stuck in the palm? Right, did you have a question?
I think Kelly did.
Oh.
Yeah, I did. I was curious if do OTs usually see it after the surgical?
Absolutely. I'll show you some pictures. Yeah. Yeah. So I love working with Dupuytren's patients. The thing is there's no research that supports that doing anything conservatively is effective. Like, they've done some studies that have shown, we increased 5 degrees after 12 therapy sessions in the use of a splint. Well, is the cost benefit, out there? And then what happens when they stop the therapy? Do you lose? There's no research that supports. So if you get a patient referred to you for therapy and you think this is Dupuytren's, it's really not ethical for us to provide therapy. Because it's not supported at all in the literature, okay? If I developed Dupuytren's, I could not help but make myself a splint, right? And I would probably stretch my own hand out, but I'm not charging myself, $127 a visit to do that, right? Because it's not supported at all in the literature. We had in the clinic, one of my OT friends, her husband has it, and it's kind of like, I don't know, did anyone in here see him in the clinic when we brought him? You guys saw him? Yeah, so he was more like this, right? And it kind of was driving him crazy. And he's a police officer, and it's his gun hand. So he's really worried about it. So something like that, maybe surgery might be an option, but his wife is an OT and she knows what it is, and so we made him a splint and we didn't charge him for it. But I would make myself a splint if I had it. But in the research, there's no support for us making splints, so we don't make them and charge people for them. Is it gonna hurt to do an exercise program? No. Could it help gain, hold off another year from surgery until a patient can retire and then not have to worry about lost income from work, But therapy for this, conservatively, is not supported.
So you say, if you did get a referral, what would you tell them, like you don't diagnose? Would you
Right,
tell
I would
them
have
or
them
them?
call I would call whoever referred and have a conversation.
Say you need something.
Yeah. And again, depending on who referred, you can't, I always tell, I was telling my kids this because my daughter was having a problem with her biology teacher or whatever, but I'm like, you can't go wrong by just asking a question, right? If you frame things in questions, it's a non-threatening way. And so if I call and say, you referred Mr. Smith and he clearly has Dupuytren's disease, and if you read the literature, you would know that that's not supported by therapy, right? Bad. right? But if you call the office and ask, or even just talk to the medical assistant and say, it could be a family doctor. Referred, the family doctor has to know kidney values, they have to know collagen, they have to know everything. They can't be expected to know everything. They might have sent them to you to help, because they don't know what else to do, right? So if you just call and say, they have nodules in the palm of their hand, and they have Northern European descent, patients between ages of 50 and 60 or is 56, and have you, do you think it could be something related to that? Or, you can't, it's a non-threatening way to have that conversation.
What if the doctor insists that it's not that, but they're pretty sure?
I've never had that happen. Usually, if a doctor doesn't know what this is, they're a family doctor. And usually most doctors will know. But if you did, usually you can have a conversation. They're not usually.
What specialty would this person be referred to?
Okay,
I mean, it's not dermatology specifically, it's not rheumatology, where would he?
right. So if you look at this, we're not going to treat them conservatively, but if they need something else, it's got to be surgery or this collagenase injection. Okay? Surgery, usually they have these guidelines, but again, they're different for everyone. Like the police officer with the gun hand, he's working, is going to be different from someone who, like an accountant, right, that has a little bit of puckering and fascia in their palm. But with this fascia, it wraps itself around everything. So if you think of what we have going through here, we have tendons, we have nerves, we have blood supply, all vital things in here, right? And it wraps around it, and it's sticky and glue-like around everything. So it's a very tedious surgery to get it out, to debride it out. Risk of nerve laceration, risk of blood vessel laceration, risk of tendon laceration. So the only person in my mind that should be doing this surgery is a hand surgeon.
Prior to being referred for surgery though, so the primary care doctor would typically refer that to who?
Hand surgeon.
Strictly, straight from primary care surgery?
Yeah. Yeah.
Gotcha.
Even if, sometimes even like the police officer, the doctor's saying, I don't think you're quite ready for surgery, but now you're my patient. When you think that it's time, you can get right in, Otherwise, if you don't get referred, then it can take a while. But this is slow growing. But yeah, you don't want just, there's nothing else to do for it. So there's no necessary to see anybody else. So I would for sure not want a general orthopedic operating on that. Because tendon, blood, nerve. If you cut the tendon, then you have to have a tendon repair. And is that surgeon able to do that? If you cut the nerve, can that surgeon do microsurgery to repair the nerve at the time of the oops, right? If the doctor cut the blood supply, the finger needs the blood to live, right? So is that doctor capable of doing microsurgery to repair the vessel? So, yeah. All right. Oh, I forgot to open these up ahead of time. So collagenase injection, I'm going to try to talk at the same time that I'm doing this. We'll see how effective this is. So the collagenase injections, I'm not seeing that yet, is they use an enzyme and they inject it into the cord, okay? So what happens is the physician injects it into the cord, you wait, you have to be wrapped up, okay? You wait, I can't remember, I think it's 2 or 3 days, 48 hours I think. And then you go back to the doctor, and the doctor basically pulls your finger open and it ruptures the cord where it was being contracted, okay? So there's been, when this started coming out, everyone's like all the therapists were like, don't tell your patients who are on the brink of surgery to hold off because this new wonderful injection is coming out and we're not going to need to do surgery on these Dupuytren's contractures anymore because it's a big surgery. They have to open that area all up, debride out all that tissue. They're really wet wounds. You know, you'll see hard to heal, you know, and that kind of thing. Usually need a lot of therapy afterwards. So everyone was saying, oh, this is going to be the best thing. And then it came out, FDA approval, and we started seeing patients that were in clinical trials that were getting this injection. And then it kind of like went rampant for a few years. Like everywhere you went, someone wanted to feed you breakfast to tell you about this injection or feed you a piece of cake or like, I mean, everywhere you went, you were just like being like choked with xyflex information, right? And then there were some tendon ruptures because if you think about it, when they vigorously and depending on how they inject the collagenase, there's a very strict protocol of how you're supposed to do it. They've had some tendon ruptures. It's very costly. Not that surgery and therapy and all that isn't costly as well. So some doctors are very big advocates for this, and some doctors got burned and won't do it at all.
When I was researching this in the field work, one thing I read is that, like, for some people, their inflammatory response is really, really aggressive. So after xyflex, the fascia grows back super fast.
I
So they
haven't
don't really
seen
know.
that, but you
Yeah.
know, I don't see a lot of people with this.
Right, it was just something that, you know, they thought it was like a miracle drug that works miracles, you know?
Yeah,
but
it was
some
it was
people-
presented as this is going to be the best thing ever.
In theory, it sounds like it would,
And
right?
in
But-
theory, it sounds like it would. And some doctors still stand behind it and are really committed to this product. And some doctors have said, no way am I being sued for using a product that's been shown to have a tendon rupture and then I have a tendon rupture. They won't do it. So this is a case study on here. So this lady, she's kind of talky, so I might just zoom through some parts to avoid that. But, so
It's Monday, June 16th.
here she is
And
prior.
actually, it's 2 o'clock in the morning.
Oh,
and I can't
sorry.
see
Oh,
because
hold on. Windows, T. Okay, let me go back. I just want you to see it.
Today is Monday, June 16th.
So you can see nodules.
And actually,
forward.
it's 2 o'clock in the morning and I can't sleep
2 o'clock in the morning, she can't sleep.
because
She's
I'm
videotaping
going
it.
out to
You can
Rockford
see she
today
has
to get
probably
the
greater than a
injection
33 MP flesh
enzyme
contracture.
injection
2 fingers where she
in my
can't
hand
extend.
to
Okay,
take care of this
so
ugly thing that's growing.
let's go back.
So Nancy, you say it's usually not painful at all?
Well, I've had
It's usually not that painful, but it looks painful. Every patient is different, right? And I would say people complain more that it's irritating. Like it bugs them because they have this thickness and they feel like they can't straighten all the way. If people let it get to that, do you think it would be hugely painful? Yeah, I haven't experienced it. But like this patient, like you know her whole life story in these videos. So, but it's just every patient is different, you know? So here she is, she had the injection, okay?
the injection, and which hurt quite a bit, but was bearable. And then they wrapped my hand in this gauzy bandage to keep it immobile.
Yep, so she had the injection, and then here she goes back to the doctor, and
Well, here it is. It's that yellow stuff is the sterilizer, and it's quite swollen, which is really excellent, a good sign.
I think it's
No bruising really, but it hurts like hell. And it feels like if I just stretched out my fingers, I would break that cord. But of course, I won't do that. I'll let the doctor do that and flip that pain on me.
Okay. So then she goes to the doctor.
Well, here's the new hand. This is after the manipulation. I haven't been able to open my hand
She still
this
has a little
far
bit of a cord.
in years. Now, it's still really swollen back here, so I can't make a fist yet because it's sore. And it's very sore where the manipulation was. If you can see that right there, how bruised it is.
Ruptured.
But I think it's really good. It was,
And here's the day after.
it's Wednesday, June 18th in the morning. This is the contraption that I
So
wear
look
at
at
night.
this
It's a
splint.
splint to keep
What
my
do you think
hand,
about the fit of this splint?
my fingers stretched. So this comes off in the morning. And my hand is still swollen,
She still can't straighten all the
but
way,
it's
right?
looking much better. And look how far I can stretch my fingers now.
The point I wanted to make is she can stretch her fingers farther than that splint was made. The splint was holding her in more flexion. Like when she straightens, she can go further than what the splint was holding her. Bad, poorly made splint. You need to have the splint as straight as you can get them. The only time that you would be worried about things like that is if they were stuck in heat like this, and then they were released. Those, remember how our soft tissue, our nerves, and our blood vessels can lengthen as we move? Well, these haven't moved in years, right? And if you pull them all the way up, they might get numbness too much. So in real aggressive cases, you might not be able to splint them all the way straight. But if they can get all the way straight and they're not complaining of numbness, they're not having clear vascular disruption, then splint them as straight as you can.
If there's a little bit of the cord still there though, wouldn't that just grow right back?
It may not, but again, it's a slow growing thing.
Right.
Who knows? It could be another 20 years and then they'll have the next best collagenase injection that can isolate only the fascia and not tendon or, you know. So like in Grand Rapids, Dr. Marilee Mead, she does a ton of these, ton of them. But other physicians in the community, I don't think will. Here she is 4 days after.
Today is Saturday, June 21st, so it's 4 days after the manipulation. I still can't open my hand all the way, and I don't think that's going to get any better, even as
She
it
still can't straighten all the way,
heals.
right? Then she goes in, injection number 2.
It is July 31st. I have the second
So
injection
I can see her.
July
Now she-
14th and the manipulation July 15th.
Okay, and then 10 months later.
Last year, I was involved in a
Okay,
clinical
this is
study
long.
to test an
Yeah,
animal.
let's get to that. So you could get a second injection phase, but again, I think it's like $3,800 to have the injection done. But if you look at the cost of surgery and therapy afterwards, depending on how much you need, you know, cost benefit. If your tendon ruptures, though, that would be bad, you know. So I don't know. I don't know. I don't do them. I don't have to make that decision, right? If it were me, I would go to a surgeon that's skilled and have it surgically removed. I don't know. Who knows? It's the patient's choice of what they want to do, right? And if you go on xyflex, there's lots of, you can go on these videos when you, if you don't want to take a lot of time on it, but they have tons of videos, and they had a really good video. I don't know why they took it off, 'cause I used it last year and it's not there when I pulled it up, but you could hear it. So I loved it because when they pulled the finger in extension, it was an audible pop that you could hear because sometimes you can hear it. This video, you can't hear it, but you can see the doctor doing the extension with it, so you can watch that at your leisure. Okay? All right. So now you're seeing both. don't know, we'll just keep going with it. So, sometimes depending on the, so now is this too distracting for you to see two slides at once? We don't have many more to go, we have 10, so. So with the surgical post-op, they'll either do a closed technique. If it's not a large area of skin that they have to, that's impacted, they can just close it. And again, it will look like that Z. It's a Z-plasty. Because if they did a longitudinal incision this way, it would just contract down again, right? So it'll be a Z-plasty, so it'll look like a series of Zs. Or sometimes they have to leave it open, which is called a McCash. So you might see on the script, duper release McCash, right? And then you know that that patient's coming with a big open wound in the palm of their hand, and you have to be ready to treat it. Have the supplies that you need, that kind of thing. So with the open technique, it's because they don't have good skin coverage to cover the wound, and they just let it heal with secondary intention. Because if they sutured it closed, it would cause contracture, right? They're going to get a skin graft over, but sometimes they don't take very well with these procedures. And through research, they've shown that they do very well with just healing with secondary intention. So really important, usually when I see these patients, they come like 2 days post-op. They come right away to get taken out of their post-op bundle and get range of motion started and get fitted for a splint. And every doctor will do different things, and it depends on the amount of contracture and trauma that occurred with the surgery, okay? Sometimes the doctor will want the splint to be on at all times. It's a forearm-based, like a paddle splint. If the index finger is not involved, sometimes I'll let you keep the index finger out. Sometimes the doctor wants the splint to be on at all times and then take it off for exercise and then put it back on. Sometimes, if it's not as significant, they might just want night extension splinting. But I put digit, but it really needs forearm-based, typically, post-op, because it's a big trauma. Sometimes they have contractures and they might need dynamic splinting to get flexion. Because if they were stuck like this, how do you think that DIP joint's gonna move? If it was stuck like that for 20 years, right? But managing the wound, managing the scar, managing the edema is critical, okay? And then strengthening I'm not usually that worried about. By the time these patients get full wound closed, full range of motion, they can start to use their hand for function, I usually set them free. They'll get strong on their own with just doing their everyday tasks. They're not a patient that I'm going to keep, oh, you're 20 pounds less than your other hand, we're going to keep you for another 6 weeks of therapy. That's not what you typically see with these. Get them full range of motion, get them functional, and they'll get strong on their own. So here's what a typical post-op incision can look like. Now what do we see here? Can you see that? White. So it's maceration. So what do we think is wrong with that? Too wet. So that wetness is keeping this from healing. So if the wound's too wet, delays wound healing, okay? All of this though is all healed. You can start scar mobilization on it. This area you cannot, you have to wick it up with dressing. I would put something to keep it from adhering, like in a zero form or an adaptic or something like that, kind of material, over just this little area. If you put it over the whole thing, then the whole thing is gonna be macerated, right? Just this little area, cover it with the dry dressing. Use only the dry dressing here because you want to get the finger moving. You don't cover that at that point. You don't need to cover it. Okay, and then here's what sometimes they look like post-op. So you can see Z-plasties, right? Here, and then here. This is McCash. So they had a combination of McCash and then closed with primary intention.
If they have a wound like that, should the splint be dorsal?
If it's really wet, you could put the splint dorsal. But I can tell you, then you gotta have straps through here. You know, so I don't usually. I put it volar, I do frequent dressing changes. And you can see, his incision are suture closed, but look at what's happening here because it's so stinking wet. It's so wet. And I knew that his hand was gonna look like that because that was the second hand that I treated of the same gentleman. So when I took the first dressing off, you're like, holy crap here, this is a mess, right? So when he had the second surgery, I was like, oh, here he's coming back, his hand's gonna look just the same. And it looked exactly as bad as the other side as he had when he had the other hand done. But these can heal really quickly. The biggest thing is control the moisture. You gotta get the moisture off the hand.
Is this one coming like a couple of days after surgery?
Yeah, he's
and then-
like maybe 3 days post-op.
So it was dressed like that, like maybe a little improper, or?
But he had the dressing on for 3 days.
Oh, okay, yeah.
Yeah, he was in his post-op bundle. And he was just draining, and he's not that swollen. I wouldn't have expected it, right? But he is just a weeper. Like, he is just draining. And his first hand did it, so I knew, I was hoping that it wouldn't, but it
So
did.
it wasn't really that he wasn't dressed properly, it's
No.
just him.
It's just him.
He just leaks.
He's not a big edema maker. Maybe he's not swollen because it all came out the incision and macerated his wound, you know? He's not that swollen. And he was like 86. But like a young 86. And he had this one done, I think, and they were waiting to go to Florida for the season. And they wanted it to be, the wound to be healed and him to have good range of motion before they left. So there was a lot of pressure, because the wife wanted to go to Florida, right? So this is the cash, this is open, sutured but open, right? All the skin, if you left this still wet, the whole thing is a giant wound, right? But we controlled the moisture balance, and like, I think within a week, it would be longer than that, the sutures would be in 10, 14 days. So, but you can see, this is all healed. This is maybe a few weeks. All healed. This yellow, again, because he's making so much moisture, right? So it's yellow, but this is really all, I was able to debride all this off. It's really flaky. Just something in the middle, calcium alginate, right smack in the middle of there. That's what I would do. And then get him moving. And then a little bit longer, he's doing good. And you can see he also has Dupuytren's here. Do you see that? It wasn't operated on because it wasn't affecting his function, and he already had enough involvement, right? But then look at his fist. Right? And then since he came, there was his other hand that we treated. Look how good he's doing. Looks fabulous, right? Full extension, full flexion. He also has it on this thumb as well, right? So that hand looked just as bad. It looked like that when he came too. But they can heal quick. I love working with Dupuytren's patients. They're usually really hardy. They're hard workers. They're good patients to work with. So then this is just a couple slides just to touch on vessel repair. So vessel repair, I'm talking about repairing vessels that provide blood to the fiber, right? Sometimes they just sew them end to end. Sometimes they use a graft. Sometimes they sew them end to side into another vessel to provide blood supply. Again, the things that we need to be concerned about is when we know a vessel has been repaired, we need to worry about how we dress it. No co-band initially over a vessel repair. No straps, splint straps over a vessel repair. Sometimes you may not be able to do full extension like if I have a vessel repair on the volar wrist, they may not want extension. Do you see what I'm, if they have a vessel repair on the digit, they may not want initially, they may be blocked in 30 degrees of flexion for a period of time until that heals, and then they allow full extension. So protective splinting, to keep tension off the repair. You don't want your patients to have a lot of caffeine, and smoking is an absolute no. And then the bad thing is these usually occur with other things because the vessels are deep, right? So they also might have fracture, nerve laceration, tendon laceration along with it. And there's research that shows if you cut the vessel or nerve along with tendon, like the more things that you cut, as you would expect, the poorer your outcome's gonna be. And sometimes that happens. So protected range of motion, splinting, and wound care is what we do with vessel repair. And I don't usually see people with just vessel repair. They usually have a couple of things going on that you're addressing at the same time. Let's take a break, huh? Take a break, and then we'll come back and talk about